Hi everyone, I'm Dr. John Kennedy. Welcome to MD-VOD, Your Health Live and On Demand, where each week we examine a medical challenge to help you better understand what the challenge is, who's at risk, the common symptoms, how to make a diagnosis, the treatments and therapies available, and whether insurance covers the costs. Today, we're talking about urological gynecology, the challenges we face and how technology is helping us address them. Each year, 600,000 women undergo hysterectomies. That's the surgical removal of the uterus. Over $5 billion are spent each year on this procedure, and of these, as many as 300,000, or half, are due to uterine fibroids. Studies also show that 20 to 30% of women of the reproductive age have fibroids, and African American women are actually 3 times more likely to develop fibroids. Most fibroids don't cause any symptoms, and many women are unaware that they have them. When fibroids become problematic, though, removing them by performing a procedure known as myomectomy might be necessary. Finally, as our population ages, procedures to support the vaginal canal, known as sacrocolpopexy, are becoming more common. Later in the show, Dr. Amy Rosenman will help us better understand these conditions. But first, let's take a look at the anatomy of the uterus. Welcome back to MD-VOD, where today we're talking about urologic gynecology. The uterus is the part of the female reproductive tract that holds the fetus during pregnancy. When not pregnant, sometimes problems can occur in the uterus, leading to abnormal bleeding and abdominal pain. Examples include fibroids, endometriosis, and cancer. Stay tuned, because up next, we'll be joined by urologic gynecologist, Dr. Amy Rosenman. Hi everyone, welcome back to MD-VOD, where today we're talking about urologic gynecology, and we're joined by special guest, urogynecologist, Dr. Amy Rosenman from Marina Del Rey Hospital. But first, a shout out to our great friends at webacina.com, who aggregate medical and health wikis, Twitters, blogs, and videos. Be sure to check them out at webacina.com. And thanks so much for joining us, Dr. Rosenman.
My pleasure.
We're talking about urogynecology, which I know is a really interesting, evolving field. Can you tell us a little bit about what are the most common sort of challenges women have today in your field?
In my field of urogynecology, which is pretty much pelvic floor disorders, the problems we deal most with are leaky bladders, leaking urine, and the prolapse of pelvic organs, so bulging at the vaginal opening that can be uncomfortable.
So I know that the anatomy, we talked briefly about it, but I know that the uterus and the bladder are sort of intimately, opposed. They're right next to each other.
Yes.
Why is it, when I was in medical school, I saw so many hysterectomies when I was doing my GYN rotation, and a lot of times it was for fibroids and endometriosis and even uterine cancer. But you're involved with something a little bit different, and it's become a field on its own, which is incontinence.
This field of urogynecology also is inhabited by urologists. They're called female urologists. And now it's encompassing one field. It's going to be female pelvic medicine and reconstructive surgery. And it will have urologists, gynecologists, and we'll all be focusing on the pelvic floor. We deal with pelvic organ prolapse, the dropping of pelvic organs, bulging. We deal with leaky bladders. But to answer your other question, why are women having hysterectomies, one reason is the prolapse. If the uterus falls and it's no longer in its pelvic location, but is actually sitting in the vagina or exiting, then one option is to remove it and reattach the vaginal tissue where it belongs, so that you don't have the vaginal tube turning itself inside out, which is essentially what's happening with prolapse. The other conditions you asked about, fibroids and endometriosis, are conditions of reproductive age women. They don't occur before the first period, and they don't begin after the last period. So they're reproductive age problems. And the fibroids are the formation of a tumor that is totally benign, made of the same cells that make up the uterus, but they're disorganized and form a ball. And this ball starts enlarging the uterus and displacing the normal uterine cells. This can be treated if it becomes symptomatic. The mere presence of benign fibroids does not require treatment. But as with all things, whether it needs treatment is dependent on location, location, or location. So if they're just hanging out, not bothering you, we don't care. But if they're in the uterine cavity, then they can cause very heavy bleeding, and that's a problem. It can make you anemic. That's a big issue. And if they're large, very large, they cause bulk, if you have something the size of a cannonball in there, it's very uncomfortable. So those are reasons to either remove the uterus with a hysterectomy, or if you prefer to keep the uterus, because perhaps you haven't had your family yet, or you just are happy leaving this world with what you came in with, which is what my patients tell me, then a myomectomy is the way to go, where you just remove the tumors and reconstruct the uterus.
So the difference between a hysterectomy and a myomectomy is the myomectomy is just taking part of it out.
Taking the tumors out, taking none of the uterus out, and just fixing the uterus. Endometriosis, on the other hand, is the formation of small cysts that are composed of the uterine lining tissue. It's called the endometrium, the normal uterine lining that sloughs every month with a period. If some of that tissue perhaps drips out of a tube onto an ovary, you can start developing an endometriosis cyst. Or it can be behind the uterus. It causes inflammation, it causes adhesions, it causes pain spontaneously, pain with periods, and pain with intercourse. This can be treated by hysterectomy if you're done having your family, or it can be also reconstructed. You can remove the endometriosis, and this is often done laparoscopically, which is a minimally invasive procedure through the belly button with a couple of small ports. If it's a very complicated procedure, it can be done with a Da Vinci robot, robotically assisted laparoscopy, and it lets us do more complicated procedures because the instruments in a regular laparoscope are straight. We call it straight stick laparoscopy. But the ones in the Da Vinci have wrists, so you can curve and you can do all sorts of complex maneuvers you can't otherwise do with the regular laparoscope.
Oh, that's great. What a great review. So we talked about fibroids, which are the tumors. We talked about endometriosis, which is sort of the natural lining of the uterus that
forming
grows
abnormal cysts.
And abnormal cysts. And those both, I would imagine, if they get big enough, can cause problems with the bladder because they're close.
They can cause problems with the bladder, but the number one cause of problems with the bladder is vaginal childbirth. Vaginal childbirth is a large head coming through a small tube. It stretches out the tissue, which can cause some neurological compression, some pressure on the nerves. It can cause some tearing of the tissue, and it can cause some stretching of the tissue. So even though we do recover after the birth, there is an injury there. And then we have the nerve to have a second, a third, maybe even a fourth child. So this multiplies the injury. But very often women don't have symptoms immediately in the childbearing years because it's also related to gravity. Gravity is not our friend in this condition because we are bipeds, we walk on 2 feet. We have a problem where the vagina is at the lowest part of our pelvis. Our, man's best friend, the dog, has a horizontal vagina. They don't get prolapse. Lucky dog. But women do, and it's related to the injury at the time of childbirth. From there, we go on to years and years of gravity. Then menopause comes along, and we have hormonal changes that weaken the tissue, and then ultimately aging takes its toll. So prolapse tends to be a problem of menopause and beyond, is when it becomes symptomatic, even though the insult begins with childbirth.
That's great, great summary and history of how sort of things happen. So let me just recap something you said I think is important. So those at risk for prolapse, vaginal prolapse, and also incontinence, I would imagine,
yes.
Having trouble with frequency of urination, urinating when you don't want to, you cough, you sneeze, are those that are at risk for both are those that have had multiple pregnancies. Is that right? Is that why the pelvic floor is so important?
Such a great question, because you have really described all problems with incontinence. The kind of leaky bladders that are associated with coughing, sneezing, exercise, change in position, bearing down, is related directly to the pelvic floor, and it is related to childbirth. The other form of incontinence, urgency, frequency, gotta go, is related to neurological changes between the brain, spinal cord, and the bladder that are associated with aging and hormone changes. So they're slightly different, and the age range for each is slightly different. The stress incontinence, coughing, sneezing variety is an anatomic problem that's treated surgically, and the other is a functional neurogenic problem that's treated medically and with biofeedback.
Wow, that's very interesting.
I hope so.
So now,
I've made a career of this.
Yeah, it's a great answer. So you tease out the cause then, and is the therapy sort of dictated by what the cause is? I mean, would you recommend surgery, for example, for everyone that had urinary incontinence?
So that's a great question, is how do you make a decision as to the therapy? And it takes into context what the patient's goals are, because these are diagnoses that we refer to as quality of life diagnoses. So if a patient were to come in and say, I leak, if I ask, I leak maybe once a week, and I were to say, does this bother you? And she says, not a bit. Then I would say it's not a problem. Because really the definition of incontinence is involuntary loss of urine at inappropriate times that causes a bother. Now, if a patient comes in and say, I leak every 2 weeks and it's really impacting my life, I don't want to go to the gym anymore, I don't want to have sex anymore, that's a problem that requires a solution. So it's lifestyle related, it's activity related, and it's quality of life related, as well as what are the symptoms and how severe are they.
What a great summary. And you know, it goes back to, it's so important to take a history because it sounds like your therapy is dictated by the history and hearing about people's lifestyle and so forth. It seems like the field is so specialized now, urogynecology, and let's say I'm an internist and I refer one of my patients to you with urinary incontinence. Does insurance typically cover the cost of the consult and some of the tests that you do to make the diagnosis and treat?
Insurance covers all of this. Let me leave our audience with one thought. Incontinence is not normal. It is not a normal result of aging. 30% of all women over 60 have some urinary leakage. That means 70% of women don't. And that should be our goal, to be in that group of women who aren't leaking. It isn't normal. It is a medical condition. It is covered by insurance. The evaluation and the treatment are covered. The only thing that's not usually covered is the use of absorbent products, and that could be quite expensive. So treating it and not living with it is a great idea.
So if you have incontinence, it's not normal. 70% of the time you shouldn't have it, right? And
That's right.
If you have it, you should go to your urogynecologist. I want to thank Amy Rosenman for joining us. What an outstanding review and some great take-home advice about urogynecology. Make sure to stay tuned, because up next on our Apple a Day, we'll learn ways to avoid and prevent some urological gynecology problems. Welcome back to our Apple a Day, where we're talking about urologic gynecology. We actually don't know what causes fibroids, though general health, good health, eating well, and exercising regularly are a great start in both preventing and dealing with most medical challenges. With regard to maintaining the muscles involved, Kegel exercises, which consist of repeatedly contracting or relaxing the muscles that form the part of the pelvic floor, are a great idea. I hope our show on gynecological challenges has helped you better understand the conditions and how technology has given us options to treat them. Make sure to stay connected and subscribe to us on YouTube, like us on Facebook, and follow us on Twitter. And don't forget to share us with your family and friends. And as always, leave us your comments and questions so that we can better help you with your health. I'm Dr. John Kennedy, and you're watching MD-VOD, your health live and on demand, here on emPOWERme.tv. We'll see you next time. Hi everyone, welcome back to MD-VOD, where today we're talking about urogynecology, and we're joined by expert urogynecologist from Marina Del Rey Hospital, Dr. Amy Rosenman. Amy, thank you.
Thank you.
We're going to answer your questions live on Facebook and Twitter. The first question up is, can you tell us how the specialty of urogynecology is growing?
Well, as
And evolving.
I may have mentioned before, it's both urologists and gynecologists. It's now going to be a board-certified specialty starting in June with a new name. It's going to be known as Female Pelvic Medicine and Reconstructive Surgery, or
Wow.
FPMRS.
I was going to say FPMRS is way easier.
Way easier. But essentially, it's because it's a multidisciplinary specialty that the names are being combined, and urologists and gynecologists are both specially trained and qualified if they have the special training to do this kind of evaluation and treatment.
So it requires tons of training, and
It does. It requires completing a gynecology residency followed by a 3-year fellowship. That's 4 years plus 3, or a urology training, which I believe is now 5 or 6 years plus
Wow.
2. So it is a lot of training.
Wow. One of the, we talked earlier about, the procedures that you do, and you talk a lot about the pelvic floor. It seems like that's sort of the problematic area.
Yes.
What is the anatomy of the pelvic floor?
So let me try to give you a general concept. We're all aware of what the pelvic bones look like. It's like a basket that surrounds our pelvic organs. You can also think of it as, I think a basket is the best way to think about it. And lining that basket are the pelvic floor muscles. We have muscles on the sides of it, we have muscles in the back, the front, and the bottom. Now through those muscles have to go our rectum, vagina, and urethra so that we can have childbirth, sex, and elimination. And those areas are the areas that are in flux, shall we say. When those areas are moving out of position and are no longer in the proper alignment, we have problems with the pelvic organs dropping, and urinary and sometimes stool incontinence.
So the floor of the basket, if you will, where all those organs come together.
It's
the
thinning
urethra, the vagina,
and
the
sagging.
rectum. Oh, interesting, huh? That's a great
And
way to
then
describe
it allows some things like the bladder and the uterus to actually slip through.
Wow. Next question up is, when would you use robotic surgery to correct some of these problems with, that arise in urogynecology?
It's actually the most exciting question because this is the new age. Being able to use there's a new Da Vinci robot at Marina Del Rey Hospital, which is just wonderful. And now we can do an operation that we've done for the last 30 years with a big incision. Now we can do it with a tiny incision in the belly button and a couple of other 1/4 inch incisions. So this has taken a tried and true procedure that we have lots of safety information on that does use mesh abdominally, like we have been doing for 30 years with very good results, and it allows us to do it in a minimally invasive way. So this is a paradigm change. It was always the best, strongest repair to do a mesh sacrocolpopexy, or attachment of the prolapsed vagina behind the pelvic structures to the bony pelvis. But it was a big operation with a large incision. That didn't appeal to too many women. They'd rather bulge, they told me.
Wow.
But now they can have the best of all worlds, a good, strong repair, minimally invasive with a Da Vinci robot at Marina Del Rey, where we have a new one, which is, I can't tell you how important that is, because the newer models are much more facile at doing these things than some of the older ones.
And you mentioned, this is a question I have, because it's so exciting, the technology is incredible, and your field has grown to be its own entity because of technology. A lot of it has to do with technology and what we're learning about the pelvic floor and how to fix it. The robot, it's interesting because laparoscopic, surgery, let's say for a hysterectomy or some of the other surgeries you do for the pelvic floor, it seems limited because you have sort of these crochet-like needles, which is great because it's a smaller incision, decreased length of stay, and cosmetically better.
Yes.
But the robot's neat because the arms spin around and turn. And can you tell us a little bit about why that's
Right. Instead of a straight thing, and you're trying to do sewing in this kind of a arrangement, you have wristed instruments that move just like hands do. So you can put in a stitch in an upside down location, and you can tie it
Wow.
like you would normally tie it. So it's really a major boon. And the other issues are that you can sit in a comfortable position, so you're not contorting yourself, which limits how long you can do a procedure. And it appears that the learning curve to become an excellent robotic surgeon is shorter than the learning curve for laparoscopy. It takes years and years and years, whereas
Wow.
with the robot, once you get along, you can learn to do a lot more quickly. So it may be the paradigm of the future. It will bring minimally invasive surgery to a lot more women because there are very few people with the laparoscopic skills to do these procedures without a robot.
Wow.
Now, I have done them with without a robot, but it's actually physically painful to contort yourself for hours at a time.
And the robot is available where you work at
Yes.
Marina Del Rey Hospital.
Yes, it
Wow,
is, and it's really made a change in what we have to offer our patients. It's a wonderful thing. They go home either the same day or the next day.
That was a great review. I want to thank you so much, Dr. Amy Rosenman from
Yes.
Marina Del Rey Hospital, telling us all about urologic gynecology. If you missed any of today's show, make sure you go to MD-VOD at emPOWERme.tv. That was a great review. Thanks a lot for your questions. We'll see you next time.